us this morning.
Yeah, thank you, Stephen, and certainly grateful and for everyone joining at this hour, wherever you are in the world. I'm the director of the Cardio-Oncology Clinic at the Mayo Clinic in Rochester, Minnesota, and also leading the ICOS Scientific Council along with Tom Nealon. And this is really what constitutes the topic of today's webinar is our first effort as a ICOS Scientific Council. We felt that given the current times, COVID-19 would be something of interest as it pertains to our cardio-oncology care. And so this is what I'd really like to share and go through the statement that we composed. And I'm just speaking on behalf of my great colleagues and many listed here who really formed this document, a lot of thought that went into it. And so I'm grateful to all of them. And hopefully many of them are on and will be able to help with the discussion at the end. And so no pertinent other disclosures, maybe other than saying that, I mean, I guess all of us, at least I can speak for myself, we've been through quite a lot the past month. And just on June 1st, our state opened up again. And so I'm not much of a hairdresser type of guy, but even myself got worried. This was the situation in our home just before June 1st came, and I was able to go to the barbershop again. The true colors came out in this quarantine life. And it's interesting. So when you look at England, the BBC, they do these things with the kids as far as the story of the year, or they can submit stories. And what's the word of the year? And I'll know about the Oxford Dictionary. So they say, the children said in England, the word of the year is coronavirus. I mean, and who would have guessed? But they also, I mean, had some very interesting thoughts. I think that's what came out of these stories, is that these kids were talking about Wuhan. They were talking about lockdown. And the other common themes, what I thought was really interesting that they even said was empathy towards those affected. I think that's really something we need in this day and age. Obviously, they were commenting on their fears and uncertainty and the need to find a cure. And someone was talking about predicting what was to come for the UK, but others looked more globally. And this is really what it was. It's a global phenomenon. When we go back as far as a short timeline of the number of countries that reported cases of COVID-19, end of January, those, I mean, 4 were listed in Asia, China predominantly, but also Japan, Taiwan. And then a month later, we had 28 countries reporting cases. As of March 1st, there were 66, and then end of March, so 2 months after January 20th, with the 4 countries, we have now 165 countries reporting cases in the world, really like a rapid wildfire. And early on, this is in the New York Times, everyone was talking about this disease, trying to put in one or more draws. How contagious is it? How deadly is it? And really, you can see in the shaded area, really difficult to predict where would we land. And mortality, fatality rates from China were predicting about 5% chance of mortality, so even higher than the Spanish flu. And then as far as being contagious, how many individuals can one infected individuals impact? So it was really difficult to predict early on, and I think we're still in a phase where it's not yet fully defined. So the way my simple view of this is the impression that we got is that COVID-19 it kills on contact. It's like rape, and it's not good, but it is tough. And one of the seminal articles, and I think this one now has over close to 3,500 citations now already. So it's a really proliferative field to publish in. One of the first studies defining the risk predictors for mortality in patients with COVID-19, stemming out from Wuhan, China. This is short of 200 patients that they looked at. And what emerged early on, how non-survivors differentiate from survivors, is that they're older. We've seen this again and again, but also the cardiovascular disease aspects as highlighted. Non-survivors more commonly had a history of hypertension, diabetes, and coronary heart disease. They also had more commonly COPD. But as you can see in this initial report, carcinoma, for instance, was almost non-existent. Not much of an initial thought in this regard. And as far as cardiovascular diseases, I mean, this is another report, again, sort of 200 patients that was looked at. The cardiovascular disease history mattered, but even more seemed that troponin elevation, troponin T elevation, really became a potent outcome predictor. And as in many other studies have been shown, around day 10 after symptom onset is where these curves differentiate. And as you can see, those with elevated troponins were worse off. If you had pre-existing cardiovascular disease, you were in the highest risk category. And this is from a nice review by Tom Gutzig from Glasgow, and really an excellent overview and conceptual figure as how to put this together and how the cardiovascular system plays into it. As we know, SARS-CoV-2 enters cells through the ACE2 receptor, and that's expressed on type 2 pneumocytes. It's also expressed on endothelial cells, on macrophages, on parasites. And it starts out with the cleavage of the S protein, the spike protein. There's a serine protease. And then becomes accessible to the ACE receptor, viral invasion, and we can see starting out with lung inflammation for one, culminating into possibly a cytokine storm. That's one big topic, and we'll see a little bit more on that. And then the other is the direct impact and invasion, if you will, of the cardiovascular system. So cardiomyocytes can be directly affected. They can also be indirectly affected by the impact on the vasculature. And as I said, parasites and endothelial cells both can be infected, literally infected. And so that leads to microvascular disease, but also macrovascular disease to the point of unstabilization of plaques and acute coronary syndrome. And so all of this then as a framework as how troponin is a reflection of what is happening in an individual's body as this virus is taking its course. And going back to the seminal paper by Fei Xu is the biomarkers that they looked at. And the three that stand out are the D-dimer, the interleukin-6, and high-sensitive troponin I. And as we can see, after 7 days, so day 10, that's where there is a significant difference in the D-dimer level between non-survivors and survivors, non-survivors having really significantly higher levels. Interleukin-6 follows a little bit later, and so does troponin. It just after day 10, it takes its exponential rise in those who do not survive. And you might have seen this 2 days ago, the press release on the success of an old story. And you might know or might not know that prednisone was discovered in a lab here at Mayo Clinic. And what was this was centuries ago. What they didn't do at the time, and they regret to this day, as you can imagine, is they didn't patent it. And so Mayo Clinic would be in a whole different situation if they had patented these kind of prednisones. And so dexamethasone, what was the success story? What was reported 2 days ago? It relates to the recovery trial. That looks at 5 different treatment strategies in a comparison to the usual care. And one of these is the dexamethasone 6 milligrams once a day for 10 days. And on June 8th, the steering committee recommended to halt the trial. And 8 days later, the results were announced that they saw. So what was seen was that 28-day mortality was highest in those on mechanical ventilation as expected, intermediate on those requiring oxygen supplementation, so 40% mortality, 25% mortality, and then those who did not require any respiratory intervention, 30% mortality. And dexamethasone at the described dose reduced death in ventilated patients by 1/3 and by 1/5 in patients receiving oxygen only. And there was no benefit in those patients who did not require any respiratory support. So the number needed to treat 8 for ventilated, 25 for oxygen requirement patients to prevent 1 death. So after all these efforts we've all learned about, this is an old drug, if you will, that's making its renaissance. And
so Joerg, I was just curious, you know, that the benefit was only in those patients that were intubated, correct?
But also an oxygen supplementation. Mm-hmm.
So, I mean, I think that's, you know, probably it has nothing really to do with COVID. It's more the inflammatory response of people that have a respiratory illness.
Mm-hmm. That's right.
So, I mean, dexamethasone can't be considered some sort of specific therapy for COVID. It's just management of a sick ICU patient.
Yeah, correct. I mean, this relates to the first aspect that the cytokine storm, as mentioned. I mean, that kind of inflammatory milieu. So I think we might interpret this in that regard, just as you outlined. So that's how I would see it. And maybe we can have more discussion at the end, because I mean, there are other strategies. Hopefully some are on the call looking at more specific interleukin-6 directed therapies, and but more to stage it in that regard. Yeah.
Yeah.
And if we look at the other aspect, so, and that's where this is the inflammation in the interleukin-6 and so forth story. When you look at the biomarkers, and as mentioned, he had, I mean, the dimer interleukin-6 and high sensitive troponin as really emerging as the top 3. In the multivariate analysis in this paper early on, the key predictors for outcome, so age, it always prevails. Coronary artery disease, as you see in the middle, actually didn't turn out to be an independent predictor. The SOFAR score was, and that's really intuitive, right, for the extent of multi-organ involvement and so forth. But when we look at other markers, which one emerged? And this was the D-dimer. The D-dimer, especially at very high level, this is the only biomarker in this early study that turned out to be an independent predictor, and very strong, right? I mean, the odds ratio of 18.4, that is solid. And I think it relates to this other aspect. We talked a little bit about inflammation. The other is the direct effect on the vascular system, and particularly the endothelium. So this was a very elegant and nice early study, a letter in Lancet. And that's how a number of great stories start, right, as letters to the New England Lancet. Now, this is from Switzerland, from Zurich, and what they did was a complete workup of patients who did not do so well with COVID-19. And what they saw were, number one, viral particles in endothelial cells in the glomeruli, the glomerular capillary loops. And you can see the basement membrane in the bottom panel there, B, in the insert, that's the basement membrane, and then on top sitting an endothelial cell, and the arrow is pointing to a viral inclusion body. And they also found, widespread inflammation of the vasculature. These in the middle panel, these green arrows are pointing to monocytes, mononuclear cells in the intima. And then to the right-hand side, we have a lung sample that showed in the middle insert, again, mononuclear cells in arteries, pulmonary arteries, but then also associated in or in that area apoptosis of endothelial cells by caspase-3 staining. So endothelial infection and decay, and that's always the setup for more to come. And so over the last few weeks, what we've seen more and more report on pulmonary thrombosis and infarction. So these red arrows, they're pointing to thrombi in auto lung, and in further aspects of this, you can see where there's, I mean, really no structure at all anymore. There was even related infarction, pulmonary thrombosis and infarction, something I think that we've increasingly recognized. And on histology, you can see this substrate, complete occlusion, pulmonary arteries by thrombosis. So I think this is the D-dimer story, D-dimer thrombosis story, I think is a really important aspect. And this is something that's just impressed thus far in JAC. This is from Mount Sinai, nearly 3,000 patients. They looked at retrospectively all those hospitalized with COVID-19 and whether they received anticoagulation in any form or shape during the hospitalization. That's the blue line, or they didn't. That's the red line. And what you can see is that all patients, but particularly those right-hand panel that were mechanical ventilation, they did way better with anticoagulation. And in the adjusted analysis, they found that the longer an anticoagulation, the better the outcome. And for any day on anticoagulation therapy, the adjusted hazard ratio of death was 0.86, so reduced by 14%. So I think these are intriguing data. This is not randomized. This is retrospective, so always with a grain of salt. But I think it is important. It pertains also to the cancer population, as we know, they have a higher, particularly with active cancer, higher propensity towards thrombosis. So this is leading to this aspect of how does the cancer population do? And there were some early studies just with 18 patients in this report, and then 28 patients in this report. And they're all indicating that cancer patients have worse outcomes. But I think the best report so far, and was published ahead of print in end of April, but now is in print, is this study looking at just over 100 patients with cancer and then comparing them with 536 age-matched non-cancer patients. And how did they do? What differences were seen? In orange, the orange line is the cancer patients, the blue line, the non-cancer patients, and we can all see that they had higher mortality, required more ICU care, more invasive ventilation. And so to the right-hand side, that's the combination of all the severe adverse outcomes over time. And clearly, cancer patients doing worse when they stratified by type of cancer. And this is now something that has also been found in the New York experience from the Bronx. It seems that hematological malignancies and lung cancer are really the ones that are posing the highest risks. In this study, I didn't put the slide in, but it seemed to be metastases, lung metastases also had an impact along with lung cancer, but the hematological malignancies, and maybe it relates to this whole hypercoagulation milieu. Metastatic cancer also, and it is said particularly to the lungs, poses the highest risk category within the cancer population. And this is something.
Yeah. So Joerg, on go to the slide you just went to, the next slide. But you had a few slides ago, you had a nice paper about certain biomarkers. Mm-hmm. In that particular study, did they measure CRP?
I would have to go back. I mean, they did a whole slew of markers they looked at. And so some of the studies, yeah, I mean, they were, generally higher. I would need to look at the details, Dan, as far as how statistically.
Yeah, so especially as it relates to what you're about to talk about right now, the outcome prediction score. I think that the CRP in that study you showed before wasn't actually measured. I don't know that for a fact, but I have to look at it myself. But there were other papers that have suggested that CRP as a marker of inflammation could be useful in this population. So
what I do know for a fact is, I mean, from the study in New York too, D-dimer levels were significantly higher in those, also in cancer patients who didn't do well. So I think it's still, I mean, the story seems to be consistent, I mean, from those two aspects, huh?
Yeah, absolutely.
Now, this is an interesting analysis. It's from JAMA Internal Medicine, where it was published, looking at a prediction score for critical illness in hospitalized patients with COVID-19. And what I found intriguing is, so let's zoom in right on the comorbidities. They found that, I mean, more comorbidities you have, the higher the likelihood of developing critical cores, which is not surprising. But when you look at all of these, I mean, it was, I mean, COPD was there, yes, diabetes, hypertension, cardiovascular disease, cerebrovascular disease, but then malignancy, chronic kidney disease, and immunodeficiency just a little bit. But when you look at all of this, and it's interesting that the only one out of the specific comorbidities that turned out to be an independent predictor and went into the model was the cancer history. And so this is now available online, this calculation tool for predicting critical ill course of COVID-19 on admission. I'm just bringing this up as far as how things have shifted a little bit from the cardiovascular disease history to the cancer history. So this population is really a high-risk population, the cancer population. And as you can see, the number of comorbidities also still within. So the cardio-oncology population is, as we all assumed, would be one of the highest risk categories for patients as they endure this disease. And there's also been some talk about increased susceptibility. Why are cancer patients at a higher risk? I mean, number one, as far as the location of the cancer, as mentioned, lung cancer turned out to be one of the highest risk categories, maybe already reduced reserve, but also smoking history, et cetera, that plays into cardiovascular disease. A degree of bone marrow suppression, or maybe any bone marrow suppression, right? As far as mounting an immune response that could be compromised as well. I mean, so too little and too much seems to be not good. It's also affected, and we had some discussion as a group about this. I mean, we all, I think, on the call can attest that there are vast differences in the burden of COVID-19 across the globe. So the severity in the region impacts it. Patients needing to go to the hospital, which otherwise may not have been exposed. Their reduced functional status, reserve, and then, as mentioned already, the need that they require often more interaction with the healthcare community. So, in a conceptual format, what we how this could be displayed is, as we've all seen this, and we've all heard the terms to flatten the curve. I mean, if we look at the P curve as the traditional, and take that as the landmark, we're going through a pre-peak, peak, and post-peak period. And so we felt, I mean, it's important to reiterate that as you're in the pre-peak period, I think there's no place on the planet anymore that's in that kind of category. But we hope there won't be future outbreaks. But I think looking ahead, I mean, we still should be, as we're going through this, still be in a mode of preparation for anything, or be ready should something like this emerge and not take us by surprise. So
Joerg, on to this point, to what you're saying, and we did discuss this in the proposal that you highlighted before, is that you can talk about COVID-19, but if you just stay focused on this particular virus, certainly it could mutate. So it could be COVID-20 or COVID-21 6 months from now. But then also, as was highlighted in our document, is that it's really preparing yourself or applying general principles to any pandemic. So whether it's COVID-19 or some other virus or whatever other infection could be out there, then this was apropos to any infectious disease sort of pandemic.
Yeah, right. And I mean, there have been manuscripts, papers, documents, however you want to call them, calling for preparedness, even among a cancer population. It's just maybe that we never have been attentive to these. And so a lot of this has really, it seems like, right, has taken us by surprise. I mean, we never thought this could happen only in movies. And we were really not prepared and struggling. And I mean, I don't know if we have the time, but there are so many aspects to this as far as supply chain and manufacturing of drugs, medical supplies. I mean, a whole lot of things that play into this. So I think really, yeah, I mean, the bottom line is calling for preparedness and for the future. I mean, so that should anything like this ever occur, we're in a better position. I mean, as you prepare and have your mind set that this is a possibility that you can deal with, during the acute peak, you would escalate those efforts, and it's very intuitive as what to do. We're all in this, and we've been through this. But then I think the other aspect is where more and more of us are moving to now is this maintenance phase. That we've been through this peak. Hopefully, we don't see a second peak. But how do we work? I mean, what's going to be our workflow now? What did we take from our initial preparation and escalation strategies and continue to maintain a safe environment for this high-risk population? And we also discussed it. I mean, the environments differ as alluded to earlier. There's a high and a low, and that also has an impact as far as the strategy. So when we look at the cardio-oncology patient before, during, and after therapy, we felt it's still important not to forget. And this was early on. I mean, our discussions were started, as you can imagine, months ago, as this was breaking out. Not to forget about the rest. I mean, there's not only COVID-19, patients still has some other cardiovascular disease, for instance, and even the oncology patients. So there still should be there should be an attention to this, but then really determine what the best treatment strategy would be, taking into context the urgency of the presentation and the cancer environment, cancer treatment needs, as well as the COVID-19 environment. So this leads to three risk stratifications. Number one would be the cardiovascular disease related risk stratification. If high cardiovascular disease risk, I mean, you would still treat. I mean, a STEMI, you would still treat as a STEMI. If it's really low cardiovascular disease risk, I mean, the end of the spectrum, there would be sort of primary preventive cardiology. You could consider deferring and just continue with the standard of care. If for the cancer-related risks, if there's a high cancer risk, I mean, you still need to treat the cancer, the malignancy. You can't wait till the COVID-19 pandemic is resolved. But for low cancer risk, there might be some room to modify the therapy, the mode of administration, the timing. And then the COVID-19 related risks, depending again on which environment are you in. Is there a community outbreak of high proportion or low proportion? That will also determine how much you can open your doors to see these patients. And so we reiterated, if there's high cardiovascular disease, for instance, patients having cardiac tamponade, having a STEMI, having a stroke, you still activate the hospital team and go by institutional protocols, modified protocols, obviously, with emphasis on protection of the healthcare personnel and the individual. If there's an urgent need, heart failure decompensation, it's still something we need to be attentive to and treat. And also semi-urgent needs That's where it starts to fluctuate a little bit. But if someone has uncontrolled blood pressure, for instance, that's also sometimes difficult to do just over the phone, particularly if the patient doesn't have a blood pressure machine at home. So the other end of the spectrum is the low cardiovascular disease risk, all these elective conglomerate, where it's just routine cardiovascular surveillance, for instance. This could be dealt with video visits, phone visits, but definitely limiting exposure to a healthcare environment infiltrated by COVID-19. And we also advocated that ideally you would know, even though the tests are imperfect, to test for COVID-19 to get a sense of the exposure level for patients and their close contacts, and to continue with universal precautions and protection strategies. So diving into our document then, as far as what we had as specific strategies and recommendations, this was one of the first. It was a statement that during periods of high virus spread and or risk, you would limit the direct encounters, virtual consults, but we also said that in-person consultations and physical exams still remains critical in patients with urgent and emergent medical conditions. So still not to forget, treat STEMIs as STEMIs. And then for cardiovascular surveillance, and I think this is really a key aspect, and the recommendation was that's critical and necessary, and a shift, and you'll see more of this, and that might form a good basis for discussion, a shift to cardio biomarker-based approach in combination with symptom assessment. That's what we stated. And so for cardiac imaging during COVID-19, and we combined proposals that were out there on the web, on the ESC side, and then also published in the ESC journals, as well as in the ACC journals, that cardiac imaging should be performed only if appropriate and if it's going to change patient management. And that the imaging modality that should be chosen would be the one that best meets the topic of interest, but also safety of the medical staff. And any non-urgent and routine follow-up exam to be postponed or canceled. And there were some calls to, I mean, some were thinking in those ESC, ACC related documents, portable, bring the machine to the patient would be the better approach than driving the patient through the hospital. And often that's anyway not possible if someone's really critically ill in shock. And a key emphasis is the duration of the cardiac imaging studies. Some of them can be performed rather quickly, so taking the transportation differences into account. For instance, ultra-fast CT is really fast, hence the name. An echo exam at the Mayo Clinic can take over an hour, on the other hand. So you want to be judicious. And the Focus Cardiac Ultrasound Study, FOCUS, is an acronym that's useful in this regard. Again, the goal is to minimize exposure risk and utilization of resources. And then finally, we included the aspects that TEE is a high risk of contamination. Anything that's aerosol generating, right? TEE would be one. And then to consider that a lot of these patients, they do get chest CTs, and to leverage them to assess not only the lungs, but also the cardiovascular system. And that's something we've done, for instance, as far as coronary CT angiography, really useful to get an assessment of the lung structure, but also of the vasculature in these various aspects, pulmonary, coronary. As it comes to cancer therapy, we felt for anthracycline-based therapy, the assessment of cardiac function should be only done or advocated in individuals at high risk. And one stratification measure that could be used are the ESCO guidelines. And that post-anthracycline therapy, It should be reserved to those who have either heart failure symptoms, have a high CV risk factor burden, elevation in cardiac biomarkers. So this would be particularly troponin. And then as they approach the higher dose spectrum of anthracycline therapy with doses exceeding 250 milligrams per meter square, doxorubicin equivalent. For HER2-directed therapy, same statement for pre-therapy evaluation. So the group felt that it should be in individuals at high risk, and on therapy, a shift to cardiac biomarkers to identify those patients who do not require routine 3-monthly cardiac imaging, but to substitute, particularly if patients are receiving blood work anyway for their cancer care. For TKIs, and we emphasize the ones that target the VEGF pathway, daily home blood pressure monitoring is what we reiterated to be of importance, and that natriuretic peptides, NPs, could be used periodically to screen, again, the biomarker-driven approach. When it comes to proteasome inhibitors, cardiac biomarkers, and Dan, you have a great manuscript on this as far as showing the merit of natriuretic peptides in this, whereas echo, as we know, is not really all that useful in patients with multiple myeloma, even on carfilzomib, and even with symptoms of dyspnea, other symptoms that may suggest heart failure. So the biomarkers have been and remain a preferred strategy here. In immune checkpoint inhibitors, this has generated a slew of discussions. When you look at the literature in cancer patients, a lot of letters, commentaries, and debates as far as immune checkpoint inhibitors hasn't come out as clearly as being a significant factor, but we don't have as much data yet. And our statement sort of reiterated what was been said before, and there's, I think, a lot of vagueness to this. We just don't know how to best do, or what to recommend, at least, let's put it that way, universally or generally recommend for these patients on immune checkpoint inhibitors. We do know, obviously, of their risk of developing immune-related adverse events, and we do know that myocarditis, though not the most frequent, is the most fatal. And combining this with the possibility of myocarditis in COVID-19 patients, I mean, it becomes difficult to differentiate what is the cause. But this treatment strategy, again, steroids coming out as being really a good choice. Now, when it comes to CAR-T and BiTE therapy, sort of a similar statement, but with a caveat, because some of us, I mean, I think early on, and then you've mentioned the inflammation story, and I mean the cytokine storm. We're all very reminded of cytokine release syndrome, and so we stated a low threshold to use anti-IL-6 directed therapies, tocilizumab, and there are trials ongoing. Maybe Tom is on; he's leading some of these efforts, and those on active cancer therapy with a compromised immune system. Maximal precaution is just a given in general for these cancer patients. And given the, yeah.
Joe, can I just add something that's
Sure.
going to be published in JACC Cardio-Oncology in September, a review of CAR-T, cardiac, basically MACE and CAR-T, which is pretty high, so that we get COVID, but in general, these patients probably would be screened with an echo before treatment, since the drop in EF or a low baseline EF is predictive of cardiotoxicity going forward. So just wanted to add that.
Yeah, good. Thank you, Joe. As far as the cancer therapies with vascular toxicities, given the aspect that we highlighted, the direct impact on the cardiovascular system, so intuitively, it doesn't seem to be a good idea, or at least, I mean, you feel that these patients are at a higher risk, who already have some compromise of the vascular system, whose endothelial cells are already compromised in their function viability by targeting, for instance, the VEGF receptor pathway. So this is something that we reiterated, and we've for the drugs that we could include, I mean, statins to be continued, but also to be considered in patients undergoing potentially cardiovascularly toxic therapies. That was another statement we included. And again, I mean, I'm looking forward to more discussions on this and what experiences others have had. ACE inhibitors and ARBs, as we all know, wonderful discussion has taken place from the very beginnings, and the recommendation is to continue them. Might be even some merit to start them. As far as for cardioprotection in cardio-oncology patients, we reiterated that these drugs are useful, carvedilol and nebivolol as well as statins. This is something we're all familiar with. It's just a reiteration. And then an important aspect, now we all know that the hydroxychloroquine story, and I say we all, with some exception maybe, accepting it may not be as useful, but it has the potential to generate harm, particularly with QTc prolongation and then the propensity to torsades and fatal arrhythmias. So an important aspect to monitor at the QT interval. It's generally in patients on TKIs in particular. This is something that needs to be standard. Those that have the propensity to develop QTc prolongation, baseline ECG, and then follow-up ECG, and maybe even use mobile devices as efforts evolve to utilize them to measure the QTc interval. So, and we can abbreviate this, time allowing, to make room for discussion. Just wanted to wrap it up what we had at the end. I mean, a comparison with the 2020 ESMO consensus recommendations that just emerged this year prior to the COVID outbreak, and then our modification. And so when it comes to the topic of baseline CV risk assessment, we have that baseline evaluation of EF with strain imaging, if possible, is useful, and I think it's useful to have a reference, because should there be a decline in ejection fraction on therapy, it's really hard to know, is this new or is this related? And so the modified consensus recommendation now was to use a TTE with or without strain or cardiac MRI as the recommended imaging modality, which we had just some specificity to this, but I think we all agreed that this would still be useful even in the current era. Now, when it comes, and I've alluded to this, and hopefully we'll have some discussion on this, is the shift from an imaging directed approach to cardiotoxicity monitoring and surveillance to a biomarker shifted approach. So what we said was, when we look at the ESMO consensus guidelines for anthracycline-based chemotherapy, statement was that there could be a consideration of periodic measurements of troponin or natriuretic peptides. And then we've changed that, that to put an emphasis on the cardiac biomarkers, that they should be considered in conjunction, particularly if other labs are being taken. And then if those become abnormal, then, or the patient becomes symptomatic, then to go to the imaging EF assessment with strain. For trastuzumab, similarly, routine surveillance consisting of cardiac imaging every 3 months. We've made the statement that in those patients who remain asymptomatic, and have, no other indication for symptoms or other concerns, cardiac imaging is not recommended. This follows through in the comparison for the ESMO and the modified ICOS recommendation, the COVID-19 era, that cardiac imaging should only be performed in those patients with symptoms, abnormal cardiac biomarkers, and the threshold in general for cardiac imaging should be higher. Also on TKI therapies, anti-VEGF therapies, but reiterating that blood pressure management, as outlined before, blood pressure measurement and management should be still continued, and it is important. So the specific in those with preclinical toxicity, number of the recommendations remained, but again, we've emphasized that cardiac biomarkers. This is anthracycline therapy every other cycle, and reassessing LV function with imaging only if either biomarker is abnormal or the patient develops heart failure symptoms. So you see the recurrent theme that went through. And I'm just moving forward a little as this is pretty much, I mean, summarizing it.
Yeah, I think the one thing, there are this has been a fantastic presentation. The one thing I would say though is, there's been a lot of discussion in the last decade about, whether you do imaging and some certain characteristic of imaging, strain or whatever. And, then they tried to compare those directly to biomarkers. And depending on which study you're talking about, sometimes those biomarkers are every bit as good as imaging and other times they're not. But the one thing that is universally true about all the biomarker studies is that if you had negative biomarkers, the negative predictive value was very high. So in a situation where we're worried about, a pandemic and exposing patients to an infectious disease, you can get a blood test without any significant exposure to the patient. And if the test is negative or normal, then you can be very confident that there's no serious cardiac safety signal. So I think that the key here is not whether biomarkers reflect changes in strain or LVEF or some other imaging defined parameter, but rather if the biomarkers are negative, then there is no reason to be suspicious because the biomarkers in particular are very sensitive.
Yeah, and I just want to add that they're already getting blood tests. So it's not, there's no added anything, not even an extra stick.
Exactly.
Yeah, that's a very important point, Dan, and thank you for adding this. I mean, absolutely, the negative predictive value that's to leverage on as far as these biomarkers are concerned, and so we use it as a traffic light, right? I mean, for the green light, we're looking, and if the light is changing, we would recommend to act. I mean, so there's this nice grid of putting it together, the 2x2 table, as far as normal, abnormal natriuretic peptides and normal and abnormal troponin, and then further stratified in the top rows there for asymptomatic, symptomatic. And putting it together, if someone has a normal troponin, normal NP, and have no symptoms, I mean, that person would be on a green status, but continue with surveillance and ideally the biomarkers for the reason mentioned. If they're symptomatic, then to look and look beyond the heart or the cardiovascular system as far as non-cardiac causes of a patient's presentation. If the patient has a normal natriuretic peptide but an abnormal troponin, and that could be, for instance, with anthracyclines. Now the natriuretic peptides, I mean, number of the, I don't know if Daniela is on, natriuretic peptides during therapy are sometimes a little difficult because of the fluid shifts, different factors impacting it. Troponin seem to have emerged, I mean, as far as, right, the marker of cardiac injury, particularly with drugs such as anthracyclines. So if there is a signal to consider cardioprotective therapy, as we usually, I mean, would do, though we don't, I mean, right, I mean, in response to the abnormal troponin, and otherwise repeat these markers, and for the patient to see one of us in the cardio-oncology clinic. To the right-hand side, if someone has an abnormal NP, but has a normal troponin, and has no symptoms, if they're receiving high-risk cancer therapy or have high CV risk, consider repeating them in 1 to 2 weeks, see what the trend is. And then if it remains abnormal, to do the cardiac imaging and the consultation. If they have symptoms, we'll go to that, straight away. And then the group in red here, abnormal troponin, abnormal natriuretic peptides, those are the ones that definitely, if you're right, need some workup, and need multidisciplinary care teams to decide as far as how to proceed with their therapy and their protective therapy. So this is our consensus document is going through a revision process in CA, a Cancer Journal for clinicians, and hopefully we have something positive in the near future. But I will really want to iterate, to my colleagues and dear friends who worked on this document, but then everyone listening, everyone out there. Thank you for what everyone has been doing with all the dedication, the passion, the commitment, courage at times. So it's really another aspect that we've seen through all of this. I think it's the beauty of our joint togetherness, and this is something we really need, I think, in this day and age across the globe. And so ICOS, the International Cardio-Oncology Society, I think is a perfect forum, and the webinar. And I just want to, at the end, mention that next week we're back on it again. Denise is going to talk about cardiovascular disease and multiple myeloma. So is this, I thank everyone really making time, carving it out of your busy schedule for today, and really looking forward to some more discussions. And it was great. Dan, Joe, thanks for adding all these various aspects, and maybe there's more we can discuss.
Fantastic. Great presentation as always, Joerg. So yeah, I think that it is a significant shift if we are emphasizing biomarker measurements as a monitoring for cardiac safety as opposed to frequent imaging. That is a little bit of a paradigm shift. So I think that I guess people are going to have to get their heads around that one.
Mm-hmm.
Yeah.
Mm-hmm.
It's about as good as you could ever imagine. And I agree with Dan that there is a paradigm shift, and maybe it's one of the positive benefits of this pandemic, because most of what we've talked about is really going to be applicable when there isn't even a pandemic. And in the controversy about ACEs and ARBs, in today's New England Journal, there are 2 observational studies and a really nice editorial, basically debunking any problem regarding the safety of those drugs in patients with the virus.
Yeah, so I think, and then of course the Plaquenil story is quite interesting. But I yesterday on various emails, I have the email notification coming from a variety of societies, so ACC and ASCO and MedPage and whatever. So there's probably 30 or 40 emails every day that I, for the most part, delete. But the thing is that all of them really touted the dexamethasone study in COVID as groundbreaking research. So I don't know what you think about that, Joerg.
Yeah, no, I think, and moving forward, I think that there are efforts, and Judith Hochman is spearheading this, I'm going back to our two favorite stories. I mean, the one is the inflammation, the other is the thrombosis, and maybe they relate, right? I mean, we've seen some of this with the immune checkpoint inhibitors, as far as becoming a topic, emerging in some guideline recommendations even. So Joerg Hermann is looking at doing a trial looking at these aspects of the thrombosis. This is something I think for our cancer patients that we, I mean, need to be attentive to, and with the inflammation too. I mean, I think, I mean, what, I mean, we've heard this statement before on the radio and on TV. What do you have to lose? But I mean, that's one of those. I think what's the downside? I'll be intrigued as far as finding out, being more specific with the interleukin-6 directed therapies. But this is obviously multiple scales more costly, right? So I think just using in countries, and I mean, we're interested to hear how it is in other nations. I can speak direct experience from Brazil. They might not have the resources to give interleukin-6 directed therapies. I mean, on the other hand, they do have dexamethasone, and they've been using it for weeks.
If I could make a point, this is Arjun Ghosh from London. Great talk, George, and thanks for the great presentation. So I was involved in the dexamethasone trial, so we were one of the sites. And I think I'd just like to kind of, I guess, emphasize the fact that these are for sick patients who are, you know, ventilated in ITU, and, you know, it's very contextual in whom, you know, we should be kind of giving the dexamethasone. So I mean, the manuscript will be coming out, etc. And I think also just to kind of highlight, so I think Joe, you kindly mentioned our paper on the CAR-T in September. So I agree that the IL-6 tocilizumab, that story is definitely very interesting, and there are some trials that are ongoing in this regard. Even at University College London. So hopefully, you know, this is something that we can look at. But I think for both the dexamethasone and again for the cytokine storm, that angle, these are specific subgroups of the patients, the sickest patients, obviously the ones that, you know, we do have to target. I think that we just need to bear that in mind.
Well, that's great. I mean, nice to hear the background. Thanks for joining. So what do, I mean, if I don't know, if I don't want to press you too hard, but again, do you think dexamethasone will do the trick, or do we need bigger guns, more costly guns? Do you think that will be as efficacious, or do you think interleukin-6 directed therapy is better?
Yes, I think the different types of patients, that even if we talk about the dex and the IL-6, we weren't using them in exactly the same patients. So and for me personally, they were being used at trials at two different sites. So again, that's why there was no crossover. So unfortunately, I personally, from my experience, I can't say that there's a one size fits all, and, you know, all the patients. As you said, George, you know, dexamethasone is available everywhere. It's cheap. You know, that should really be something that we should consider first before something like tocilizumab, which, you know, is only available in certain countries.
So, Arjun, would you say anybody that's becoming progressively hypoxic that looks like they're going to go towards intubation, that, and you of course are suspecting COVID-19, or whether you've proven it or not, would you give dexamethasone in that setting? You know, in all of those patients?
Yeah, so that's a fantastic question, Dan. So I don't think that that's kind of how the trial was really set up. So the trial was more along the patients who, you know, are already down the pathway. You know, they are already intubated. So whether it works as a preemptive drug, difficult to say, because that's not exactly what was being looked at. But in this context, you know, I could say, what do you have to lose, like somebody from across the pond. but I don't know if that's necessarily, you know, the best approach to take if we haven't actually specifically looked at that in a trial.
Okay, well, thank you so much for getting on the call, of course, but also, you know, sharing with us your perspective on that research. Obviously, it was very important to the cardiology community, that's for sure.
Yeah, no, fantastic. So anyone on the call who has already made the shift to a biomarker approach? I'm just curious. Does everyone feel comfortable with this?
Yeah, Teresa from Madrid has been on. I don't know if she wants to say anything, but be interested to know what she thinks about all this. I think that we, mainly because I harp on and on about this type of topic, but at WashU, we are not exclusively biomarker based, but we're very amenable to following patients via biomarkers.
Hi, Dan, I'm interested. Yes, we generally use biomarkers, especially cardiac troponin. We have not a great experience with NT-proBNP just as a monitoring tool, and but we use a lot BNP in patients who develop cardiotoxicity in order to monitor cardiovascular treatment. Is it true that some of our oncologists are not very comfortable with biomarkers monitoring, especially in patients who are not breast cancer patients? That probably we have the greatest experience in patients with breast cancer treated with anthracycline and trastuzumab. But in this patient, we use biomarkers combining with the echo, sometimes cardiac MRI, but most of the time echo in daily practice.
Well, Joerg, this has been absolutely fantastic. We've captured everybody's attention across the world for over an hour, so I think we probably should let you off the hook, but we really appreciate your presentation. Has been really fantastic.
Well, thank you so much. It's going to continue with a great presentation next week. I mean, Anish, fantastic. So I'm looking forward to
it. Absolutely. All right. Well, you guys take care, and we'll see you next week.
Thank you all
Thanks.
so much.
Okay, bye.
All right.
Bye-bye.
Thank you. Bye-bye.
Thank you,
Thank
bye.
you. Bye-bye.
Bye.
Thank you very much.